Good day, you all. This is my review of this vaccination position statement. I really want to just talk about some of the things that I think are important in this paper. It's not all the things I think are important in this paper, and I encourage you to read the entire paper. It's very short and easy to read, and come up with your own notions of what do you think is important here. And then we're going to talk about that. Some of the things we're going to discuss this week are what was the value of this vaccination and what would you do to promote it given what you now think about its value, whether good or bad. So this paper was published by a German team. They published it in November of 2023, and they're basically wrestling with how valuable are the new RSV vaccines and what should be done with them. If you're going to read the entire paper, you get the bonus of being able to skip the abstract. The abstract is for when you're in a hurry and you just want to see, is this a paper I want to read or not? In this case, we've already decided we're reading it, so we can skip that and go straight into background. Background is where they will usually say, well, okay, what's up with the disease? So they define it as respiratory syncytial virus, or RSV. It is a disease of the young and a disease of the older population, so not so much a disease of younger, healthier people. They use the term pre-diseased adults, which really to us is comorbidity, but conditions such as COPD and heart disease, maybe kidney disease, chronic illnesses would be those comorbidities that predispose people to getting infections like this, respiratory infections. So also think about immunocompromised folks. Those people are also at higher risk. It used to be we really had no idea if someone was suffering from RSV because we didn't have a point of care test available. Now we basically do. I've seen them. It's a swab test for the nose, and it can detect RSV DNA, and we can see, oh, you've got RSV, or you don't. You probably don't, or you probably do. Now, having said that, we have no specific treatment for RSV, so there's not a lot of reason to check for it because we can't do anything for you if we determine that's what you've got. We can do non-specific therapy such as oxygen and fluids and rest and things like that, but we don't have any antivirals that specifically treat it. And the authors go on to say that life-threatening RSV is pretty rare. There are people who get hospitalized for pneumonia from RSV, similar it looks a lot like flu or pneumococcal pneumonia when that happens. And they go on to say, well, people at higher risk have these diseases I already mentioned, and are immunosuppressed or have cardiovascular disease, lung disease, that sort of thing. And they summarize, we're still in the background, they say, well, there is a monoclonal antibody. There's actually a pretty good one that came out in 2022 that is a one-injection monoclonal antibody. That is for prevention. It's still not a treatment. We don't give it to people who already have RSV. It's just a preventative. It's passive immunity. So the monoclonal antibody, the nirsevimab, goes away after a good number of months. So it's usually given in the beginning of the winter season, and it wears off over the winter, but that passive immunity does last long enough to prevent a lot of infections in little kids. That's not what this article is about, because this is really on the vaccines. So we don't vaccinate children currently against RSV. We have no vaccine for children. So we do have vaccines for adults, and they were approved in the EU in summer of 2023, and they were approved in the United States in May of 2023, and there are two competitors, one made by GlaxoSmithKline called Arexvy, and the other one is the Pfizer product that we'll get to in a moment. They both target the same protein on the outer coating of the virus, the RSV virus, and they break down in this study what the efficacy of the vaccines was. So The trials included adults 68 years of age and older. The GlaxoSmithKline trial, they had two arms, 12,464 and 12,494 patients, so over about 12,500 patients per arm. One arm got vaccine, the other arm got placebo. And then they say, okay, what happened after one RSV season, a winter, went by? And they say, okay, well, for RSV-associated lower respiratory tract disease, so that is a mild pneumonia, which they were able to get a positive RSV test, so they know the pneumonia was from RSV. They showed efficacy of 82.6% protection, and the way they got that 82.6% figure was there were 40 cases of disease in the placebo arm, and these were RSV-associated disease. They had a positive test, versus 7 cases in the vaccine group. So keep those numbers in mind. 7 patients in the vaccine group out of 12,464 and 40 in the placebo group out of 12,494. So 82.6% sounds pretty good. The actual number of cases I just stated, where they come up with that number, it's right here. If you have 7 people in the vaccinated group who get sick, 40 in placebo, you divide that, 7 divided by 40, that gets you to 0.175. So you can therefore say, well, the rate of infection was about 17.5% in the vaccinated group of what it was in the placebo group. And that is the inverse of 82.6. If you take 100% and you subtract 17.5%, you get 82.6%. So that's all it is. That's basically the math they're doing. I will say that the reason they didn't come up with 17.5, they had a 0.6 there, is because the size of the two groups was slightly different. If the group sizes were identical, then they would have gotten a clean 82.5% versus 82.6. But that's basically what they're doing. They're saying 7 people got sick and vaccinated, 40 got sick in placebo. Rate of infection for the vaccinated group was about 17.5% of what it was in the placebo group. So that's where the efficacy number comes from. It's not anything fancy. It's just a division of who got sick. So then they went on to say, okay, well, for people who had severe disease, there was 1 case in the vaccinated group and 17 cases in the placebo group. You do the math on that, 1 divided by 17, you come up with 94.1. So what this tells us is the virus is better at preventing severe disease. Now, there was only 1 case of severe disease in the vaccinated group, and there were only 17 cases out of 12,494 in the placebo arm. So keep that in mind. But as is normally the case, these respiratory vaccines usually are better at preventing severe disease than they are at preventing mild disease. We saw this with COVID. People who were vaccinated very rarely got really, really sick. They still got COVID and they still got sick, but they very rarely went to the hospital. Whereas people who did go to the hospital were usually unvaccinated people or people who hadn't already survived a bout with COVID already. So the vaccines seem to be better at preventing severe disease. And they actually had some data after 2 seasons which showed that efficacy went down to 67.2% for the basic disease, and it went from 94.1 to 78.8 in the group which was getting protection against severe. So in year 2, the second season, efficacy did drop somewhat, also not unexpected. Moving over to Pfizer, this is a Brisvo. You get ads on television, someone playing a trumpet. They're working with the theme of breathing. This is a Brisvo. Similar chemistry with the vaccine. It is not identical, but it is similar in what it is targeting. They also went for patients of 60 years and up. They did things a little different their definitions of disease. They said, okay, was it lower respiratory tract disease involving at least 2 signs and symptoms? And then they tell you what signs and symptoms they were looking for, cough, wheeze, etc. So did the patients get that? Or did they get 3 signs and symptoms, so more serious, and in both cases longer than a day? So they didn't go for basic RSV infection and severe. They said, were there 2 symptoms lasting longer than a day, or were there 3? And their efficacy came in at 66.7% for the 2, which was the more mild, and 85.9% for the 3. Now again, look at the numbers, the specific numbers of people who got sick, 11 in vaccine group versus 33 for the 2 sign and symptom group, versus for the 3, the more severe, it was 2 cases versus 14 cases. So small numbers of people getting sick, and they had a slightly bigger trial, 18,000, almost 18,500 patients per group. So yes, it was effective at decreasing numbers of 2 symptoms and 3 symptoms, more effective at stopping the more serious 3 symptom for a day or longer, but numbers small. So the German team who wrote the paper then went on to say, okay, well, now we've had over 30,000 people get vaccinated in 2 different studies. There were some adverse effects, and the usual stuff was they sort of gloss over, but this would be the sore arm, the fever, the lethargy, what you're used to seeing from flu and also COVID. But they say that there were some inflammatory neurologic events, which there were 6 of those, 3 in each trial, and they, so what is this about? Well, Guillain-Barré is an inflammatory neurological condition. It has a funny spelling. Apparently French were involved, where the spelling is that, or the disease is that, it's a progressive weakness caused by weakness from the nerves, and usually patients then get better. But it can be so bad they'll need ventilator support in order to breathe. It can also be quite mild. They just feel a little bit of problem in their feet or something like that. And it usually goes away. No one died in this study, but there were some cases. Now, we don't know if the cases were caused by the vaccines or not, because you can get Guillain-Barré without ever getting vaccinated. However, all 6 cases were in patients who did get vaccinated within 6 weeks, and there were no cases in the placebo group. So it seems like vaccines may have been the culprit. This is nothing new. About 1 patient in 1 million who gets flu vaccine will get severe Guillain-Barré. More mild versions of Guillain-Barré are more common than that, but it is well documented for influenza vaccines, and not really a surprise that it showed up here again. So the authors then move on, and they say, okay, where is this useful? They say using the vaccines will help the most at-risk population, so that's 60 and up. They say the data is in the population 60 and up. They say, well, in these people with these pre-existing conditions, they may actually get some benefit for people who are even younger, people with malignant hematologic diseases, leukemias, things like that, pneumonias, histories of pneumonias, things like that. And they say that the disease burden is of RSV overall is a little underestimated. It didn't get a lot of airplay until the vaccines became available. And they talk about the same vulnerable groups who we're recommending COVID, influenza, and pneumococcal vaccines to are good groups to start with. They mention price, 213 euros. You'll have to look up current comparison of euro pricing to dollar. Usually it's pretty close to $1. And there you go. So that's just the data. It is what it is. I ask you to consider, well, how serious is this condition? Where is the best benefit? And what do you want to do? Now that you have this information, you're armed with it, what would you like to do? What would you advocate doing for vaccinating people for RSV? So I'll leave it there, and thanks for listening.